Hi, welcome to this next video. This is a chance to think a little bit about carbapenems, a class of antibiotic that you may remember as sitting at the very top of the antibiotic ladder. Imagine the situation now. So we've still working with our pediatric patient who's been prescribed a whole bunch of antibiotics. They've really had everything thrown at them. And imagine a situation where you're working with someone and they say, well, hang on a minute, you've tried everything except the drug that I would normally select in this case, if you're not sure, and that is you switch over to Meripenem. Meripenem is the drug that everyone seems to treat as a little bit of a joke, because if you're not sure what's going on, you prescribe Meripenem and then you move on, you get on with the rest of your day. But why is that? And what are the benefits of using Meripenem? And why would we pick Meripenem over everything else? Yes, it's likely to work, but does it work on everything? And are there some things that it's slightly better for? When we talk about a strong antibiotic, remember, there's no such thing as a strong antibiotic, but Meripenem is often the thing that people think about. And the reason that people think about it is that resistance to Meripenem is generally very low. And it allows us to treat previously untouchable strains, so things like AMP-C and ESBL, which I'll come on to shortly. It allows us to treat them with an antibiotic. Antibiotics is a bit like photography in the sense that it's all about the exposure, meaning that the more that you use an antibiotic, the more that you expose microorganisms, you expose bacteria to a particular drug, the more that resistance builds up to it. And so more than ever, when we think about antimicrobial stewardship, these drugs are treated absolutely with really careful care and consideration, because they're, in some cases, the only thing that we have left to treat some of these very resistant strains of ESBL, E. coli, and other gram-negatives, for example. I mentioned Meripenem. It's not the only carbapenem that you're likely to come across. Let's go through the coverage of Meripenem. There are certain things that it's very good at treating, and there are certain things that you just wouldn't use it for. So right now, we'll say that it just doesn't work on everything, even though it's the so-called top of the tree, a quote, strong antibiotic. It doesn't work on everything. It doesn't work on MRSA, for example. So if you had an MRSA infection, you wouldn't use Meripenem, you would switch to another antibiotic. And in fact, even in this series, we've seen that vancomycin might be an option that you'd consider. It works on strep, and theoretically it works on enterococcus, but you wouldn't use a carbapenem to treat an enterococcus infection. But the reason for that basically is that its coverage is so wide that if you had an enterococcus infection, you would probably switch actually to something with a narrower spectrum. You wouldn't, it would be, you're throwing the kitchen sink at treating an enterococcus. There's no need to cover all these other things. Meripenem works very well on the gram-negative, so it covers lots of enteric gram-negative rods, it covers the respiratory gram-negs, and also it covers Pseudomonas. So again, we've gained coverage there against a whole range of different things. And thinking about what class of antibiotic Meripenem is, it belongs to a carbapenem, and a carbapenem in itself is a beta-lactam. So it means that it doesn't work on some of the atypicals. It does work on anaerobic bacteria. So that includes both the oral and the GI anaerobes. And so for that reason, you may see Meripenem used in GI infections, for example, where you'll have a combination of some gram-negatives and some anaerobes as well. So there are certain things that it works against and certain things it doesn't work against. And looking at it, you might think to yourself, well, it's very similar to Pip/Taz when that came up and had its own video. So why would we use Meripenem? Why not just use Pip/Taz? The reason that Meripenem is kept in reserve is basically that it works against some of the really most drug-resistant strains that are out there. So specifically, you may hear something called AMP-C, and you may hear of something called ESBL. So the picture on the right, this illustrates what we mean by AMP-C resistance. Both AMP-C and ESBL are both different types of the enzyme beta-lactamase, and AMP-C is an inducible type, and this is the enzyme that we see in the space organisms. So in previous videos, we've mentioned space organisms, and these are the things which previously may have or may be susceptible to a certain antibiotic, but when they're exposed to it, they actually switch on the production of a of a beta-lactamase enzyme. This is it. They switch on the production of AMP-C. What happens is that the drug, which you see at the top, enters the cell. It then results eventually through a small genetic circuit at the transcription of the AMP-C or mRNA. That becomes translated to the protein, which is then exported into the space. This is the periplasmic space, and the gram-negatives load up this small pocket of space between the inner and outer membrane. That becomes loaded with the beta-lactamase enzyme, and that breaks down the antibiotic as it enters the cell. And then the ESBL refers to the extended spectrum beta-lactamase, and that's slightly different, but gives coverage and protects against lots of different beta-lactamase antibiotics. That's not as inducible, but if it's present, then it's very difficult to manage. And that's certainly one that if you had a patient with an ESBL infection, you would certainly be or talking to microbiology and getting their input on what is going on. But basically, if you have an infection with these things, switching to a carbapenem is probably going to be your best option. Let's go back to our chart, and we can now add in Meripenem. You'll see also in there is Imipenem as well, and the coverage is pretty much the same. You start to see some subtleties in dosage, but we're just going to consider them the same. So we see a little bit of gram-positive coverage, but then lots of anaerobic and gram-negative coverage. And look, we've got coverage against Pseudomonas and the Escapum organisms, and these are the space organisms over here. But what about Ertopenem? Whenever I think about Ertopenem, I always think about the image that's on the screen. This is an image from a book called Microbiology Made Ridiculously Simple, and it portrays Meripenem as gorillicillin and Ertopenem as monkeycillin. Why? Because if you look at the name Ertopenem, you'll see there's ape is spelled out in the middle of it. And ape are the three organisms that are not covered in Ertopenem. So it's a slightly, if we want to use the term weaker, it's a slightly weaker antibiotic. It just doesn't cover those three things, and they are Acetobacter, Pseudomonas, and Enterococcus. And again, that's okay if you're treating an infection. Let's say you've got an enteric gram-negative infection that happens to be producing an ESBL. Then you wouldn't necessarily need to cover Pseudomonas if that wasn't part of your, the story with the particular patient you're working with. And in that case, maybe working with Ertopenem might be better. There are also differences in terms of how it can be dosed. So there are some advantages of Ertopenem in that it can be dosed with a single dose at the start of the day. I think I'm right in saying. So subtle differences. And again, when we go back to our chart and we add Ertopenem in, it gives you pretty much identical coverage, except that we've now got a gap where we have Pseudomonas. Acetobacter isn't mentioned, although of course it is part of the Escapum and space acronym. So actually, although it is here, there should be a little asterisk there just to say that it's not entirely complete coverage of these organisms. The very last thing to say. These antibiotics are top of the tree, resistance is low, but they're not infallible. And nature has now produced a so-called Carbapenem-As, and you may hear of a strain called KPC1. This is the name of a particular strain called the Klebsiella pneumonia Carbapenem-As, and this is a particular enzyme which is related to another beta-lactamase called NDM1. That stands for New Delhi beta-metallolactamase. And these are both enzymes which have very wide spectrums of activity, which allow them to break down carbapenems. Remember that once resistance to antibiotics has evolved, you can't unevolve it. But what you can do through the principles of stewardship are to create conditions where it's less favourable for these organisms to persist if they have if they happen to carry this gene. And we do that by removing the selection pressure. So if these drugs are used sparingly, if they're used when appropriate and not just all the time, then it makes it, the conditions are slightly less favourable to drive the evolution of resistance to the carbapenems. That's all for now. Thanks for listening.